subject today that I'd like to talk to you about is active surveillance. Active surveillance is a term we give carefully following men with low risk or low aggressiveness prostate cancer. It's often very tough for patients to understand how we could have been diagnosed, or how a patient could be diagnosed with prostate cancer, and then we might recommend not treating them. That seems quite counterintuitive. So let me bring you through some of the rationale around active surveillance and why we think it's an important management strategy. And I'll go through who is a good candidate for active surveillance, what are the procedures around active surveillance, and how safe is it really. The term active surveillance means a man could have been diagnosed with prostate cancer who otherwise would be a good candidate for treatment, but the cancer is so low risk or low aggressiveness that it may never progress in his lifetime. So to treat it would be unnecessary. If the cancer is never going to grow and never going to cause harm or behave like we visualize a cancer would behave, why would we expose a man to the side effects of treatment? Almost by definition, that's over-treatment. So why would we even think about this? Well, we've discovered that there's a group of men who are diagnosed with prostate cancer that are in the population that never seem to progress. We know about 50%, or about half, of 70-year-old men have microscopic, low-grade prostate cancer. Half. And in the majority of those men, they're not developing advanced prostate cancer, metastases, all the things we think about that are associated with cancer. Well, what's interesting when we look at this indolent or slow-growing cancer is it typically has some reproducible characteristics. Usually men have a relatively low PSA, prostate-specific antigen. Almost always they have low-grade prostate cancer. Grade is the Gleason grading system. Usually it's Gleason grade 3+3. It's almost always low volume on biopsy. Matter of fact, typically it's less than a quarter of the biopsies that a man has to diagnose his prostate cancer should be involved with cancer, and no individual biopsy should have more than about half of that biopsy core involved. And they should have a low PSA for the size of their prostate. That's a term we use called PSA density. So if a man has a PSA of 6, that's a high PSA, but if he has a 60 cc prostate, that's a big prostate, then that PSA divided by prostate volume, or PSA density, is 0.1, and that's reassuring. So the criteria for the best men who are candidates for surveillance, or the prostate cancer characteristics of the men who are candidates for surveillance, are PSA under 10, Gleason 3+3, normal rectal exam, we call that clinical stage, T1C, low volume on biopsy, no single biopsy over 50% involved, and a low PSA density, PSA divided by prostate volume. If a man meets all of those criteria, and we follow him carefully, we know from large series of following other men with prostate cancer, his chance of developing metastases, which is cancer that spreads to bones or lymph nodes, that of course is what we all fear when we're diagnosed with prostate cancer. The chance, if a man meets all of those criteria, that he's going to develop advanced or metastatic prostate cancer is well under 1% at 15 years. 1%. And it's well under that. So most of those men should not be treated. Now, how can we be so sure? We don't actually want to make that decision for only one point in time. We want to use time as an advantage for us and follow men carefully. So the actual procedure we use for active surveillance, if a man meets all of those criteria at diagnosis, we'll enroll him in a careful active surveillance protocol. Usually we'll repeat a PSA about every 6 months for the first year. We'll do a gentle rectal exam at least once a year. We'll repeat typically an MRI and a prostate biopsy within a year of the diagnosis. We call that the confirmatory biopsy. We're confirming that he's really a good candidate for active surveillance. We can also do genomic testing, which is look at the genes that are abnormal in the cancer, which gives us kind of an extra indicator of the safety of active surveillance. There's some commercial genomic testing companies that can help us do that. And then if he's a good candidate for surveillance, we'll follow him carefully over time, and we might repeat the MRI every 2 years, and the biopsy, we may repeat it every 2 to 4 years. So again, in the old days, which was 5 or 10 years ago, we would do a repeat biopsy every year. Men don't like repeat biopsies, we know. So now we're doing less frequent repeat biopsies as long as all of the other parameters are safe. And if men stay on active surveillance, all the criteria are the same, we think it's extremely safe. So if a man starts on active surveillance, what's the chance he'll stay on active surveillance for 10 years? The answer, it's around 60 to 70%, depending on the parameters at entry. So about a third of men, the cancer will change over time, and we may change our recommendation to treat. And that could be with radiation therapy or surgery. So again, active surveillance is a strategy of avoiding over-treatment for well-selected men with clinically localized, very low-risk prostate cancer. I want to caution you to include your physician in decision-making. I'm not trying to replace your relationship with a physician. I'm simply trying to augment your knowledge about these topics. If you'd like to go to some excellent resources, the National Comprehensive Cancer Network, or the NCCN, has excellent patient-related resources that discuss these topics. UC San Diego Health and the Moores Cancer Center is an NCCN institution, and I'm on the NCCN Guidelines Committee for Prostate Cancer, and you can just look up nccn.org online, and I think those are great patient-related resources. If we can provide care for you at UC San Diego Health, of course, we'd be delighted to. Thank you.